Progress. It's a national organization aimed at getting future health professions interested and excited about primary care. And I have with me.
I'm Eileen.
I'm Heidi.
I'm Jocelyn.
Yvette.
Okay.
Oh, sure.
So, just to get a feel for who's in the room, can we have all students raise your hands? Woo! Trainees! People currently in the workforce. Yeah! Do we have any community members? I think we're all community members, right? Like, yeah! Hand out of there. Okay, well, so happy to see everyone here with us tonight. So our theme for the evening is trust. And to follow with this theme, we have a quote by Stephen R. Covey. Trust is the glue of life. It's the most essential ingredient in effective communication. It's the foundational principle that holds all relationships. As some of you may have noticed, we have a banner in the foyer that we hope you will feel inspired throughout this evening to jot down a note for what trust means to you on Post-its and stick it up so that we can share it kind of throughout the course of the evening and see, what does trust mean to all of us, because it's a very important, I think, concept in our careers moving forward and in life in general.
So we're very grateful for the support of our many sponsors this evening, who are UCSF Student Life, the UCSF Associated Students of the School of Nursing, the UCSF Associated Students of the School of Medicine, and National Primary Care Progress Organization. We also want to thank our wonderful speakers for sharing their stories tonight. We could not have done this event without their generosity. We want to remind everyone in the room that although the stories will not contain protected health information, they may contain personal information, so be thoughtful and respectful when talking about this event with others.
So guiding us through the night, once again, is Dr. Joseph Pache. Dr. Joseph Pache was born and raised in New York City and moved to the Bay Area by way of Philadelphia in 2000 to attend the UCSF Primary Care Internal Medicine Residency Program based at San Francisco General. Now, is everywhere San Francisco General? In 2002, during his second year of residency, he began working at Tom Waddell Health Center, the city's flagship healthcare for the homeless program, where he was appointed medical director in 2011. He was motivated to become a primary care doctor as a way to contribute to the cause for social justice. In addition to his clinical and administrative work, he teaches in the primary care residency program at San Francisco General. In 2015, he received the Jane Bilowitz Award for volunteer teaching at San Francisco General. Outside of work, Joseph is coming up on 10 years as host of City Visions, a weekly live public affairs call-in show on local public radio 91.7 FM KALW.
And lastly, let's have a round of applause for the wonderful storytellers today. And a round of for our sponsors. Thank you for supporting us and the food and drink.
Yeah.
Again, thanks to everybody here for joining us and celebrating in primary care. We trust that you're happy.
All right. Hello, welcome. Good evening. Good evening. Wow, it's very loud. So my first question is, and some of you, well, actually, let me ask this question. How many of you have been to an event like this before? That's pretty good. Okay, good. So this is the first time for a lot of you, so welcome. So for those of you who know me and those of you who don't know me, do you trust me? No. No, good answer. Because I told Anna, when I walked in here and I saw the banner and I realized this evening was about trust, I had it in my head that the evening was about hope. So I hope that I can gain your trust through the course of the evening, that I can get you through the wonderful stories here and have some moments of connection as a community as we think about this theme of trust. So because I had nothing prepared to talk about regarding trust, we're just going to go right in to the evening. This is what, our 7th-ish?
I think 8, yeah.
Okay, and evening, and so we're excited to see it thriving, and it's because of the students of UCSF that it keeps going, and then the fact that you come and want to hear stories and people want to tell stories. Storytelling, obviously, is another type of glue that holds us together. Trust being the other one that you heard about earlier, because it's the way we understand each other, it's the way we make meaning, and it's the way we kind of nourish ourselves in the work that we do. So I'm really excited to hear the stories that we have. So what we're going to do is going to go through 3 stories first, then take a break, and then you'll go get more food. When you come back, we'll read some of your post-it notes up there, and then we'll do 3 more stories, and then the evening we'll wrap up. All right? And so we've asked the storytellers not to bring note cards up with them and to just tell the story, right? And they're still figuring out what they're going to say. So yeah, it's going to be a really interesting evening. And yeah, about 10 minutes per story, and inspiration from so many storytelling programs that you might hear on NPR had a lot to do with how this night of events came together. So let me introduce Marilyn Stebbins. She's going to be our first storyteller. Dr. Stebbins completed her undergraduate studies at UC San Diego in 1984 and her PharmD at UC San Francisco School of Pharmacy in '88. After the completion of her primary practice residency in pharmacy at UC Davis, she spent 7 years developing and implementing pharmacist-run clinics at the VA outpatient clinic in Sacramento. As faculty in the School of Pharmacy here since 1996, she has worked on developing innovative practice models in the physician group practice setting. And since the passage of the Affordable Care Act and the need for more community-based providers, her goal has been to extend her work in the physician group setting and to develop innovative team-based practice models in the ambulatory and community practice setting, as well as in transitions of care. Her current research interests are in comprehensive medication management and the need for an accurate medication list in these settings. Oh yes. You're a person after my own heart, the need for tidy lists. All right, let's welcome our first speaker, Marilyn Stebbins.
I don't usually need a microphone, so if it starts humming, yell. So when I was asked to do this, I thought of myself as a storyteller, but not a patient storyteller. I'm pretty good at telling stories, but this was really a bit difficult for me to try to figure out. So I want to give you some context. So for the past 13 years, I've been running a program called Partners in D in the community, where we go into the community and we do Medicare Part D plan evaluations for people that nobody else does them for. So limited English speakers, non-English speakers, and low-income individuals. And we do this as an elective program, and it's become an interprofessional elective program. And in theory, we go into these low-income housing developments, and we help people pick a Medicare Part D plan, but that isn't always what happens. So I want to tell you a story about an elderly gentleman that we were helping 2.5 years ago during open enrollment. And we went to a low-income housing facility that we're invited into by the social workers who then recruit our clients to come and meet with us. And when we walked in, first we knew everything was not going to be great. It's the first time we'd gone to this site, and it was under construction. And so they led us not to like a conference room where we could divide up and meet with people individually, but they led us to an apartment that was a studio apartment with a kitchen that was under construction. There were jackhammers hammering away outside, and it was incredibly small, and I had 14 students that would be working in pairs, and I had a lineup of people standing outside the door that wanted our help. And the first gentleman that was at the door came with a box, and his box looked like a gift box, and we took him in, and he was in the kitchen. So we took him into the kitchen, and he didn't speak any English, and we have interpreters with us. And we began looking at his box. He showed it to us, and it had all kinds of medications in it. And then it also had a 7-day pill box. And any of you that have looked at people's pill boxes, it wasn't exactly set up the way you would think a pill box would be, but basically he took his bottle and stuck each bottle into one of the days. So it was all the same pill. So he had 7 different pills, types of pills in this pill box. So initially we knew already this was not going to be a simple task. We then looked in the box, and in the box were all of his other medications. There were many that were dated long ago, so we assumed he wasn't taking them. There were the ones that we think that were empty, we think were in the pill box that had recent dates. And so we initially, antennas went up and we went, this is going to be a little bit more difficult. So we began talking to the interpreter or talking to the patient through the interpreter, and we asked if we could take the medications and just sort of categorize them, and he flew into a panic. He didn't want us to mess, we could look at them with him right there. So trust number 1. He had no idea why he should trust us to look at his medications. So I worked through the interpreter, and it can be a little overwhelming, a lot of students, descending upon a patient. And so I talked to him and said, we need to know what meds you're on so that we can figure out what's the right plan for you. Well, we started looking at the meds, and there were some very high-risk meds. He was on blood thinners, and he was on diabetes medicines, and he was on antihypertensives. And so we thought, this is not simple. We could take what he told us, because he told us the medications he was on were in that 7-day pill box, the 7 pills that were there. But we still weren't sure what all the rest of these were. He just keeps them with him. So as we talked further, he began to tell us that he was a bit concerned because he had an appointment coming up. And he didn't understand the appointment. So he pulled out this slip of paper and he handed it to me. And the piece of paper was a referral. And it was a referral to a retinal specialist. And on it, it said, legally blind. And so I began asking him, tell me about your vision. And he said, I can't see you. And he said, everybody's blurry. And so I said, tell me a bit about how you manage your medications. And he said, that's why they're in here, because I can see, I open them up and I can see colors there better than I can see them in the bottles. And so I see the colors, and I don't know if they're the right colors because everything's blurry, but that's how I take them. I then looked at his bottles, and he's non-English speaking, and his bottles are all in English, right? His labels are not in his language. And so I began asking, tell me more, tell me how you do this. And he said, I think I do a good job. I really am diligent. My medicines are mostly once a day, and I just go down the line. And I said, have you ever noticed when you get your medications and you pour them in there that your color scheme is different? And he said, yep. I said, what do you do? And he says, I just still take one of everything. And I said, okay. I said, because every one of your medications that we're looking at in here is generic, and every month when you go to the pharmacy, there's a chance that the manufacturer has changed, and the shape, the color, and everything is different. And he looked at me and pretty terrified, but he then gave me his box. So a piece of trust had come up there, so he showed me his referral. I explained to him what type of a doctor it was. We began talking about how he gets his medications. He gets on a bus, and he goes down and he picks up his medications and he brings them back, and he just takes them and dumps them in. And I said, do you run out first and then you go to the pharmacy or do you when they get low? And he said, sometimes I do it when they're low, sometimes I do it when they're gone. And I said, so tell me how you know which container to put them in if they're not out. He said, well, I don't. And we knew that because we saw some extra pills in each one. And so we said, okay, this is, we can help you. We think we can help you. And his Medicare plan had nothing to do with the visit that we had with him that day. His Medicare plan was fine. He was a dual eligible. He was in a plan that would cover his medications as far as we knew. But then I started deploying my minions, and I had students calling the pharmacies, finding out which ones he'd refilled recently. I had someone call his primary care provider who wrote the prescriptions to find out if they had a list of medicines that the patient was on. And then I had another student that was basically deployed to find me someone who would bubble pack his medications and deliver, because this poor guy was going all over the place to try to figure these things out. And then we started asking about family support, and his children lived, 45 minutes away, and he didn't want to bother them, and so he didn't really express to them what was going on. And we asked, do your kids know that your vision is failing? And he said, I'm not sure. I haven't really told them that it's failing. And so we literally spent 4 hours with that patient. He was our first patient to show up that day, and he stood there in that kitchen, and he was the last patient to leave, and we still didn't have him fixed. I mean, there was no easy way to fix this. But we had a patient who at one moment I thought was going to bolt on us because we were messing with his system. And it turns out he had a system, and because he was so visually impaired, he was so terrified of us messing up his system so that he wouldn't know what he was doing. So I think, my students looked at me and said, how can this person manage their meds? And I said, you have no idea. We have millions of people out there doing things like this, and look at, he is doing absolutely the best thing that he can do for himself, and he's really trying. So it's our job to facilitate that for him and to get this set up. So we spent about a week working on this and getting his medications transferred to a pharmacy that would bubble pack. We then were able to engage with his permission, his family members, and let them know. And at the end of that day, I left him my card. A month later, I'm in my office, sitting up in the U building in Parnassus, the 5th floor that you can never find because it's next to that Perlman Eye Institute. And I get a knock on my door from my admin who says, somebody's here to see you. And I looked out, and it was the patient with his son and his daughter. And they came in with a plant, and they just wanted to say thank you. And it was really touching. He came all the way to UCSF, climbed those, up to that god-awful building, and he actually found me, which most people on campus can't even find me. So I think that my story and trust is that, you do have to earn people's trust, and you have to also understand maybe why they don't trust you initially, and it's not always because they don't really trust you, but it may be that they don't trust themselves to have anybody interfere with their circumstance because they're afraid they won't be able to manage the way they have. So he was a great success story. I keep in touch with him. He will occasionally, I go back every year, and so he's always the first at the door. We've given him a new system, so he doesn't come with his box anymore. And we also were able to dispose of all of his medications that he was no longer taking so that there weren't confusions. So he taught me a lot about trust, and I think he taught my students even more about the need for trust when you go in and work with individuals. Thank you.
Thank you for getting us started there. So what I thought of as as you were telling the story of how you open the box and then there's the box in the box, is the amount of poise and restraint you must have shown. Because how many times have people had an experience where they come across something and you're like, how could this be, and how is this person alive, and I must fix this right now, because this cannot be, this is just awful, and then you have to pause and say, wait a minute, this person made it to see me, they must have done something right. So, yeah, so in gaining his trust, you had to trust that he had a system, right? So you inquired about it, as opposed to just assume that he was just a mess, right? The thing was a mess, but he wasn't a mess necessarily, right? And that's really important, to slow down and to trust that people have things that have gotten them to where they are. Maybe they can be better, but the more we try to push things to be our way, then that trust just evaporates. So just the poise and restraint, because how many times can you be like, oh my God, and you have to just say that to yourself. Inside voice. Daily, right? So thank you for that lovely story. So we're going next to Larry Boly. Dr. Boly's career in medicine started out in private practice in internal medicine in Mount Zion Hospital at UCSF's campus there at the beginning of the AIDS epidemic, where he became an HIV specialist out of necessity, which is very common in those days. And we have a great long tradition of people who've done that. This led him to work with the AIDS Education Training Center, which brought him into the California State Prison System at San Quentin as an HIV clinical mentor. The experience was so profound that he accepted a full-time position at UCSF at the Correctional Medicine Consultation Network, where he continued to provide HIV consultative services for the California State Prison System. Subsequently, he accepted a position as an HIV clinical mentor in Namibia, where he lived in a remote part of the Kalahari Desert and focused on perinatal HIV transmission. Upon returning to the U.S., he accepted a position at Contra Costa Regional Medical Center, where he continued to provide care as an internist and HIV specialist. He later became interested in the opioid epidemic, and as chairperson of the Safe Opioid Prescribing and Review Committee, became involved in developing policy and guidelines for safe opioid prescribing for the county. Let's welcome Larry Boly.
So I'm Italian, so this is dangerous. So I'm so honored to be here. I want to thank each one of you, and although I said I don't trust you, that's not true. One of the things that I do feel very strongly about is that each one of us in this room has been called to do what we do, and that fundamentally we need to trust that calling. I'm probably the least likely person to be a physician. You know, I'm this gay guy, right? I'm 4 years old who's afraid of blood and guts, and I get this calling from above. You're going to be a doctor. It's like, are you kidding me? I don't think so. But one has to learn to trust, all right? And even though it didn't feel like, how am I ever going to get through this blood and guts business? I did. So trust is a really, really interesting thing. I have, and storytelling is a fabulous thing. I actually work at the Healer's Art with Rachel Redmond, who is like the storyteller, guru. And Rachel's been so inspirational in my life, and the connections that I've made with medical students that I've had through the Healer's Art, I trust them. So what is trust, right? So I can speak about being a physician, believe it or not, because I've been one for 38 years, and I kind of think I know what it's like. And one of the things that I realize about trust is that there are two foundations. If you're going to trust me as your doctor, one is I better know what I'm doing, right? And I better know how to do it, right? So the foundation of trust is your clinical expertise, so you gotta study hard, you gotta know all of that stuff, okay? You gotta know cis trans, right? And the other thing is you do have to have your clinical skills. You need your expertise. If I'm going to perform a procedure on you, I better be able to do it correctly. And let me tell you this, if you get that cadre of medical acumen, and you get down your clinical skills, and guess what? You can move into the space of trust. Now, I have been in a lot of really, really strange situations as a physician. You know, I kind of get afraid of blood and guts. It's like, okay, well, you're going to be a surgeon. No, I don't think so. And finish my residency, and there's this epidemic going on. And these, so men my age, and back then, I mean, I'm a much older now, but were dying. And we didn't know what they were dying from. And that was really pretty horrific. So there wasn't really a lot to kind of help me to how I can gain someone's trust for a disease process that I didn't know anything about. I had no armamentarium to treat them with. All we had back then was AZT. And as you probably know, we were not using AZT correctly. And I was in private practice for 20 years, and I became very interested in really how do I provide care for those who don't have a voice. Because for me, that's what I felt I could bring to the table. I could speak for those who didn't have a voice. So I became very interested in now just becoming an HIV expert. And I accepted a position at UCSF on the warm line, the perinatal hotline, post-exposure prophylaxis hotline. And in that position, I'm actually involved in the AIDS Education Training Center. And this brings me into San Quentin Prison. Well, it's like, does anyone know why they call it the slammer? No. Well, it's very bizarre. I'm assuming no one's been in San Quentin Prison, right? I mean, it's not some place where you just say, hey, no, I think I want to see what it looks like.
We are the student there.
Oh. Whoa, so have you been in that?
Yes, I
Yeah,
have.
so you know when you go in, it goes
Yeah.
slam, slam,
Yeah.
slam.
Yeah.
And that's why they call it the slammer, because the doors actually slam behind you. So I kind of like trust, well, where am I, right? What surrealistic setting am I in? I'm in San Quentin. How do I proceed? What am I doing here? How do I do it? And who is my mentor? Who can I think about, like, you know, okay, I'm going to think about Rachel, and Rachel would do it this way. Well, Rachel didn't go into prison. Rachel didn't do these things, so I didn't have that kind of person. And it was like, okay, well, I'm going to trust my medical knowledge. I'm going to trust my medical skill set, and I'm going to trust myself. I'm going to trust myself. I'm going to enter into a space where, guess what? I'm going to provide a service to a patient in a setting where service is not the optimum thing, right? It's safety, you fool. And in my attempt to provide service, I often was seen as a safety risk. Bad boy. I've often been a bad boy. But I've gotten pretty far. I do not follow directions, so I don't know how I ever got this far, but I did. So I'm in San Quentin Prison, and I think that, oh my goodness, if I was in prison, what would I want from the person who's going to come in to provide me a service? And that's how I moved, okay? That's how I moved. I just trusted my instinct of what would I want from that person if he was going to provide care to me, or she was going to provide care to me. And that's what I trusted. So here I am in San Quentin Prison, and I'm working with Betty Dog. I don't know if you know Betty, she's the head pharmacist.
Well.
Yeah, she's like fabulous. So Betty and I are sitting down with the patients and going through all the beds and showing them the pills. And you know, it's like, as you see, it's like this top-notch care that we're bringing into the prison. It was like so fabulous, you know, it's really, really wonderful. And one of the patients doesn't show up for the clinic appointment. So at that point in time, you know, although I've been reminded that, Larry, you represent UCSF, you have to behave because, you know, I tend to not behave. And, okay, I do represent UCSF.